Hello, you are listening to 1 in 2, a Manchester Cancer Research podcast, brought to you by the University of Manchester and the Manchester Cancer Research Centre. With 1 in 2 of us receiving a cancer diagnosis at some point in our lifetime, it has never been more important for our research to improve the outcomes for people affected by cancer. I am your host, Sally Best, and throughout this series I'll be speaking with Manchester cancer researchers about their innovations, discoveries and projects that are changing the landscape of cancer detection and treatment. In this special episode, we speak to Dr Emma Woodward and patient Nick Brown about hereditary cancer predisposition. Specifically, we focus on Li Fraumeni Syndrome, an alteration in a specific gene which Nick carries and which results in a very high lifetime cancer risk. We discuss Nick's involvement in the ATLAS study run by Emma in collaboration with Ontario Institute for Cancer Research, which is looking to improve the standard of care for the early detection and screening for patients with Li Fraumeni Syndrome globally. Hello, everybody. It's a special episode of 1 in 2 today. We've not done a special episode in ages, and I love them because they're special. And today we have the amazing Dr. Emma Woodward and our special guest, Nick Brown. How you doing, guys?
Hello.
Hi, we're good, thanks.
You good? You good? It's been raining today in Manchester, obviously. Classic rain clouds, but cannot affect our moods, can it, guys?
No. Not at all, no.
Nope.
We've got to remain happy.
It's nice and warm in here, so that's the main thing.
Yeah, it's blooming boiling, and especially with the three of us, there's a lot of heat. But yeah, I'm so excited for today. We're focusing on hereditary cancers, and we've got our expert and Nick, who is our patient or pre-viver. We'll kind of come on to that. But I mean, just to start off with, could you introduce yourselves? I'll come to you first, Emma. Just a wee quick introduction.
Hi, so I'm Dr Emma Woodward. I'm a consultant clinical geneticist and I specialise in hereditary cancer predisposition.
Amazing. And over to you, Nick.
Hi, I'm Nick Brown. I'm a patient of Emma's and I live over in North Yorkshire, Harrogate, and I'm married with 3 kids.
Amazing. And you still got a smile on your face.
I've still got a smile on my face. That's because I'm semi-retired as well.
Well, thanks so much for joining us from Harrogate. I know it's no small feat to kind of get all the way over here, and we really appreciate it for sunny Manchester. But yeah.
No problem. For once, the M62 was clear, actually, which was a good thing. An unusual thing as well.
Look at you go. Incredible. Goodness me. And I mean, so we're focusing on hereditary cancers. I'm wondering, Emma, could you just tell our audience what a hereditary cancer is, like what that means?
So, yes, most cancers arise as what we would call isolated events. So that means gene alterations have been acquired and cause the tumour to develop. Where there is a hereditary cancer predisposition, the individual has a gene alteration in a high-risk gene, but that gene alteration is part of their underlying genetic makeup. And that's most likely something they inherited from one of their parents.
Amazing. So we spoke in season 1 to Gareth Evans. You do a bit of work with him. And we spoke about BRCA, and that's obviously kind of a form of hereditary gene. So we've got BRCA1, BRCA2 mutations.
Exactly.
There's kind of other hereditary genes that we've talked about previously. But yeah. And you work on Li Fraumeni Syndrome. Have I said that right?
You certainly have, yes.
Crikey.
Sometimes we shorten it to LFS.
LFS. We'll call it LFS so that we don't have to keep on with the long name and my dodgy pronunciations. So that, I understand, is a cancer predisposition syndrome or condition. I know you don't like using the word syndrome. But I mean, could you explain a little bit about what that is and what it's caused by? And then also, you know, we talk about hereditary, and I'm wondering about the kind of chances of passing that on to offspring and the chances of inheritance.
Absolutely. So, Li Fraumeni Syndrome is a hereditary cancer predisposition syndrome. And individuals with this condition have an underlying hereditary alteration of the TP53 gene. It's rare, it affects about 1 in 5,000 individuals, but sort of intriguingly, in sporadic cancers, the TP53 gene is the most commonly altered. So it is the normal function of TP53 is really crucial in cell division. And essentially its role is to repair mistakes in DNA. Individuals who have an altered copy and one copy of the TP53 gene are sadly increased risk of particular types of cancer. So it's really important that we then put early detection and cancer prevention measures into place.
Amazing. And that's what we understand as a germline mutation.
Exactly.
So I may butcher this, but
yeah,
look at my biology degree.
You're spot on.
So that's the alteration that happens when a sperm and an egg meet.
So this most people, essentially has to have started somewhere.
Yeah.
Most individuals will have inherited the gene alteration from their mum or their dad.
Okay.
In a small number of individuals, the gene alteration will have arisen in the sperm cell or the egg cell that conceived that person.
Okay.
And also in a very small number of individuals, the gene alteration can actually arise post-conception really early in embryogenesis. So it's present in most of the cells of their body, but not all.
Yeah. So embryogenesis is when that embryo is forming.
Exactly. And very early at that sort of
Amazing.
2, 4, 8 cell stage.
Okay. And then in terms of the hereditary nature of that, what is the inheritance factor?
So if an individual has a gene alteration in the TP53 gene, then any children they have a 50-50 or 1 in 2 chance of having inherited that gene alteration. And we know, when we know the nature of the gene alteration in a family, we can then offer testing to family members.
Okay. So that's quite high, really. If you've got, 2 parents, one of them has this TP53 or LFS, the other one doesn't, and you have 2 kids, the chances are that 1 in 2 of those will.
Exactly. And it is stressful for families. So in
Yeah.
the genetics clinic, we do our best to guide families through what options may be available.
And we'll come on to that. And obviously we've got Nick. You're sat here as a. Do you prefer patient?
Patient's fine with me.
Patient's fine with you. Great stuff. Just need to check. And I mean, how did you find out that you had Li Fraumeni syndrome or this TP53 alteration?
I suppose it first started off back in the early 90s. My mother unfortunately passed away. She had multiple sarcomas. And I think back in the day, there wasn't the same genetic testing going on. It was just she was unlucky and very unlucky to have so many primary cancers. And the information wasn't really available then. However, so she was in her early 50s. And then my sister, who unfortunately passed away back in 2016, was a similar age, in her early 50s again. And by this stage, I think the genetic testing had improved significantly. So she, I think she subsequently found out, well, after she passed away, we found out that she had this genetic alteration. So originally the alteration that, the gene alteration that for TP53 was led to, I think it was, Emma will know more than me about this, but it was deemed to be a slightly lower risk. So anyway, I had the test for the gene myself over in Leeds, which is local to me, to Yorkshire. And as a result, and I found out I had the genetic alteration, but I was told at that stage that the gene, that the alteration wasn't a high risk.
Yeah.
But then I subsequently got a letter through which said that it had changed, it had been upgraded to a high risk. And I think at that stage, I was referred then to come and see the genetics clinic in Manchester.
Okay.
And I made the promise to my sister when she was very ill that I would get tested for whatever I could do. So that was my kind of, as a result of her really, that I had the test done.
Okay. And is it just you and your sister, like the siblings?
Yes, just 2 siblings. I've got 3 children, which I'll come on to later. And my sister was married with 2 kids as well. Okay. So obviously it's got the same kind of impact on their family as my family.
Yeah, and it's so difficult. I'm so sorry that you've had to go through that. And obviously, thank you so much for sharing your story. It's really humbling. And I think it's really important as well. So, I mean, I'm just going to ask kind of quite simply how your life has changed since receiving that diagnosis.
I suppose I got the diagnosis quite late in life. So probably in my early 50s, probably.
Okay.
So I'm sort of in a way lucky that, touch wood, I believe I'm cancer free at the moment. Yeah. I've had a few lumps and bumps which have come up on scans, but they've turned out to be not malignant or anything. Yeah. So, if I'd have been diagnosed and was aware of it, perhaps at my kid's age now, I would have worried a lot more because as you're going through those sort of stages of growing up, you worry about things, you worry about your body changing, and how if you're not so well, you worry that something's kind of more serious. So I suppose for me, I'm in a way fortunate that I found out later in life. But what it does mean is that if you do feel unwell, then you tend to think, is it something more than just a bug, a tummy bug? If you get a little lump on your skin, is it more than just a boil or whatever? So it makes you more aware of and more on edge, really. But I wouldn't say it wholeheartedly changes my life. Life must go on. I suppose the other thing which has changed is that I come to Manchester every year for an MRI scan and then I either get a letter from Emma or I see Emma to hear the results.
Okay, amazing. And are you more kind of acutely aware of cancer risks? So like smoking, drinking?
Definitely more aware of it.
Yeah.
As I said before, I don't think it's wholeheartedly changed my lifestyle. I'm not a smoker anyway, so that's good. But I wouldn't say it changes what I do. It just makes me more aware of what may be happening. And I sort of feel in a way that I'm lucky because, and Emma will know much more on this than I do, but I suspect there's lots of gene alterations kicking around out there that we don't even know about that cause illness and things. And this is, and I'm sort of in a way fortunate enough to know that I've got a gene alteration and that therefore it can be monitored and reviewed. So I feel, although a little bit unlucky to have the TP53 and LFS, I do feel fortunate that I'm being reviewed and scanned and stuff. Yeah,
for sure. And Emma, so can we just cover, because we've mentioned kind of lumps and bumps and scares and things, is it 5 or 6 cancers that LFS causes a predisposition to?
So there are a few sort of core cancers, and I think one thing to bear in mind, as Nick has outlined, that actually TP53 gene alterations can affect, the consequences can actually affect children as well as adults, and that's clearly of a concern to parents. So the main tumours that can occur are soft tissue sarcomas and sarcomas of the bone, and again that can sadly start in childhood through to adulthood. In childhood, adrenocortical tumours, and then also brain tumours, and in adult women, breast cancer. So while it's still quite a range, and that is makes it challenging for families and also for prevention and early detection.
Yeah, I mean, that's quite a range. Sorry, Nick, are you going to say something there? No, you're all good. So coming to you again, Nick, I mean, Emma's just mentioned the 50% chance of passing this on to your offspring, and obviously there's quite a few childhood cancers there. I'm going to ask if it's okay, what's this diagnosis meant for your family?
So my family are all aware that I've got the genetic alteration, but it was tricky because I suppose when we first found out I had the alteration and that my sister had it as well, the children were in their early teens, early to mid-teens. So, and also when I first found out it, as I mentioned before, the risk wasn't deemed to be as significant or as high as it is now. So initially we kept fairly quiet about it and thought there'll be a time and a moment to address it. Although actually with hindsight, I wasn't aware that and perhaps the scientists weren't aware either, that the key times when it can impact on someone is when they're young, or when they get older, kind of probably in their 60s or 70s. I know it can happen any time, but I wasn't really aware that it could impact on people when they were kind of young kids. Unfortunately, again, touch wood, all my children are through that age. They're aged 20, 23 and 25. So not in the clear, and who knows if they've got the gene or not. They are just going through the process at the moment of wanting to be tested and to find out, and I personally would recommend that to them if they ask my view. But as Emma said, it's 50-50 for each child. So I've got my 3 children, my brother-in-law, so my sister's husband has also got 2 children. They've both been tested, and I think they're waiting their results as well, or they're waiting to collect their results. So the difficulty for the family is there's 5 children in the pot, and it's highly likely that 1 or 2 or all 5 of them even may have the gene, or the gene alteration. So how we manage that and how we deal with that, if one person's got it and one person hasn't, is going to be a real challenge, I think. So that's something we've got to look at in the future. They're just like normal kids who get on with life, and I'd expect them to and hope they would do.
Yeah.
You don't quite know at the back of their minds at the moment if they understand the significance. And also, as I mentioned before, it may be irrelevant if they haven't got the gene, at least for them, but it could be for their sibling.
Yeah. And it's still relevant for you, of course. And I think, people do shine in adversity and show a lot of strength. And also, I think it's one of those knowledge is power things. And I'm really sorry that it probably will be difficult conversations. But I think understanding the kind of how you can be empowered and the research that we'll come on to is really quite, extraordinary, I'd say. So I think, even though it's those difficult conversations, I hope that you can feel kind of some light at the end of the tunnel sort of take on things. So, I mean, coming on back to Emma here. So is it LFS increases your chances, is it by 70% of developing a cancer?
So the
What's the
quoted risk figures are a 70% lifetime risk. One thing that Nick has highlighted beautifully is that the data we have is completely dependent on the sort of families that have initially presented and in whom Li Fraumeni was diagnosed. So with more and more genomic testing, we are now finding TP53 gene alterations in slightly perhaps a sort of spectrum of cancers that perhaps doesn't quite fit the original textbook definition. And so that's why, and again, one of these changes in about the past 10 years, there were really, really strict criteria for defining gene alterations. So as Nick has explained beautifully, you have to get the evidence together. So in his situation, the initial evidence was not certain, but actually now it is looking like to be cancer associated.
Yeah. And so season 1 of the podcast was based on early detection. And we basically discussed the importance of early detection through, the diagnosing early and the kind of ability to have that curative effect, more so than the kind of later stages. Is that kind of why this early detection is important in Li Fraumeni?
Exactly. It is incumbent upon us to try and intercept or detect those cancers that are going to be clinically important. We need to get in there early.
Yeah.
And that is, early detection and prevention are actually the most effective means of curing cancer and so that individuals can live longer.
Yeah, for sure. Okay, and we're going to come on to your study here. So it's ATLAS. This has completely slipped over my head as another acronym, but we were discussing before the multiple depths and meanings of ATLAS. Tell me about ATLAS, Emma. What was the inception of ATLAS? What was it looking at? And we'll pull you and Nick, because obviously you've got the involvement in this study as well, but it's your little brainchild, isn't it, Emma?
Right. So I'm trying to think. Back in early 2022,
Okay.
I was invited to an online meeting that Cancer Research UK had organised in conjunction with the Ontario Institute for Cancer Research. So I duly joined online. And there was a presentation from Dr Kim in Toronto talking about using circulating free DNA as a means of early detection in Li Fraumeni syndrome. So immediately it sparked my interest.
Yeah.
And I was hooked. And I sat there thinking, I thought, well, we have the genomics knowledge.
Tick.
We have a large clinic and we have a group of really dedicated patients.
Yeah.
And also the current standard of care, the whole body MRs, an MR, it is the best standard of care we have, but you've got to go to the big hospital. I don't know if anybody's had an MRI scan. They are not the most pleasant. They are noisy.
Yeah.
They can be quite claustrophobic. So actually, we have a duty here to try and think about alternate means of early detection. So essentially, I was hooked. And then after the meeting, I dropped Raymond an email. And as they say, the rest is history.
Oh, love it. So yeah, circulating free DNA is a sort of biomarker. And we had that conversation with Caroline Dives. So she's in the Biomarker Centre in episode 1 or 2 of season 2. Don't test me right now, guys. So yeah, that would be presumably taken from a blood sample.
Indeed. So as our cells die, which is sort of natural tissue turnover, they release DNA into our body fluids. And essentially, we are using blood because blood circulates around our body, and actually a blood test is a relatively easily accessible means of getting at this circulating free DNA.
Amazing.
And I think what's really quite novel here is that historically circulating free DNA, I mean, it has been used to sort of monitor disease and monitor people who sadly have a cancer and might more therapies be indicated. But we're actually right at the other end of the spectrum, and it is, can we find alterations in that circulating free DNA that might be indicative of a cancer before a person feels unwell?
Yeah.
Might it be at the same time as imaging findings start to look a bit abnormal, or perhaps even before?
Okay. And so you've said the rest is history. So you've set up this study, ATLAS, which is a acronym for, is it early detection and Li Fraumeni Syndrome?
Indeed. And also it's a little play on words,
Yeah.
because an atlas, it's like a compendium of all these genomic changes in the circulating free DNA. And I should say, so having reached out to Raymond, we then had lots of online meetings with the Ontario Institute of Cancer Research. And then we put in a formal funding bid that was between OICR and CR UK, and it is joint with Dr Trevor Pugh, who's the PI in Toronto, and we were fortunate enough to be awarded the money.
Amazing, love it. So in terms of the aims of this study, so we were going to come on to it, but I think, Nick, what's your current standard of care for your screening for Li Fraumeni syndrome?
So currently, I get the letter from the genetics. But the letter arrives probably about December time, and they're kind of in amongst the Christmas post searching for.
I'm sorry.
No, it's okay. Don't worry. And then so letter comes in saying, please can you make the appointment for the MRI scan?
Yeah.
It's probably in a month or two's time. So I tend to have mine in Q1 each year, and then. For me, the worst part, and Emma mentioned it actually, is the MRI scan. I've had loads actually in the past, and it is a bit, if you're claustrophobic, it's not great. But you go in there, and the worst thing is these days there's a mirror. So as you're lying down, you can choose your choice of radio station, which is good.
Desert Island Discs.
Exactly, yes. Radio 5 for me probably, but and then you have the headphones on. But then you're facing the ceiling, and they have this kind of mirror system, so you can actually see people what's going on in the background.
Oh, good Lord.
And they're by the computers.
Yeah.
And I remember one time about a couple of years ago, I was there lying down, sort of looking at what's going on.
Yeah.
And I could see all these kind of people in white coats coming through, and they were looking and pointing at the screen, and I was in there for ages, and I was thinking, what's going on here?
Yeah.
And I was panicking. I thought, this doesn't look good at all. And anyway, as I walked out, I said to the guy who was in charge, I said, "Oh, that didn't look too good, did it?" And he said, "What do you mean?" I said, "Well, I was in there for ages, and you were all crowding around the screen." And he said, "No, that was because we were training." And
I told you that before.
And I said, "Phew, thank goodness for that." But no, that's just like a small anecdote. But in reality, the worst time actually is waiting for the results.
Yeah, I can imagine.
I tend to think that if there's something majorly wrong, you may get an early alert. And again, touch wood, for me, I've always had the all clears on these things.
Yeah.
Apart from picking up things like torn cartilages on my knees, which I already knew about.
Running Carrera's over then.
Absolutely. Squash actually was a sport, which does wreck your body. So yes, for me, that's my care at the moment, is that I have the annual scan. Mm-hmm. And if anything comes out of that, I'm not yet in that situation. So I don't know quite what would happen, how I'd get referred if something did come out of it. But having said all that, I know that I can call Emma or one of her secretaries, and if I've got any concerns or questions, and I do have lots of questions. That's in my nature.
That's good. It is good.
Then I know there's an open door policy there, so that's good. And I don't have to go via my GP to get referred either.
Yeah. Yeah, so it's just the straight referral letter. Amazing. So it's a kind of, annual thing. So it's obviously, it's a very expensive form of screening practice, as we know. Yeah, go on, Emma.
So, as Nick has also illustrated, the problem with any early detection test, well, it shouldn't be a problem, but there's always that risk of, as soon as the radiologist sees something, they're obliged to report it. And that can be quite anxiety provoking, because actually then the person needs more investigations. It doesn't turn out to be anything, but those sort of months in between do cause individuals, quite understandably, a lot of anxiety.
Yeah, I can imagine. So just coming back in terms of the aims of this study, it's to develop that new side-by-side screening process that would supplement the current screening regime. So that would be those blood tests that would be looking for the circulating free DNA.
Exactly.
Okay.
And I think actually, and one thing to point out is from having done our patient public involvement group, and thank you, Nick, for leading on that, a really important message that came from that, and this is why patients and families have got to be at the heart of our research and research design, is that for people and families who have a high-risk cancer predisposition, there is a security to be gained from going, let's say, annually, but for having that contact with the large teaching hospital and access to the resources there. So being able to do something that's, for example, just on a blood test totally locally might work totally in the sporadic situation, but for high-risk individuals and families, you might actually going forwards need that sort of mixed currency approach.
Yeah, for sure. And is this study still open for recruitment, or?
Yes, it is.
Yeah?
It is.
Wow.
We have funding through to next year. What we are doing is there are new people coming through, and also what's actually really important is for this is the sequential nature of the blood samples, because it is changes that we are looking for. So individuals such as Nick have been really kind and are quite happy to do sequential blood samples every few months for us.
And back to you, Nick. So how did you become involved in this study? How did you hear about it?
I think last time I met up with Emma, so back in 2022, this was, she said, we're possibly doing this study, and would you be happy to be involved? And so I said, sure, anything I can do to help or to improve the knowledge.
Yeah.
So then I got a message through, and would I be involved in the group? So I said, yeah, very happy to be. I think the feedback group was how we called it. And then myself and another person who was in that group were asked if we could be, I think they were called the patient advocates.
Yeah.
So perhaps just trying to, along with the other people on the Teams meetings, to I suppose make people feel a bit more at ease, so they're not necessarily speaking to highbrow medical people who use long terms, but more like someone like myself who's also a patient as well. So I think the idea was very much to the patients were a key part of that group, so that the feedback they gave on what happens at the moment and what may happen in the future, and their reaction to that was really important.
Yeah.
So we had a few Teams calls and we did have some very important people on, both from Manchester and from Canada as well. I think it was really interesting for me as well, because it's the first time I've ever spoken to anybody who's also got TP53, from different families. And one thing that came out for me was that people were clearly, it was nice for them to be able to speak to people who were also suffering the same genetic alterations, so they didn't feel quite so isolated. So I don't think that was one of the reasons for the meetings, but that was certainly an outcome which I noticed. People felt it was so nice to speak to somebody else who they were in their own little bubble, really.
Yeah, I can imagine. Yeah, that kind of strengthening numbers and shared experiences. I bet it's quite humbling, really. And what involvement have you had then?
So, well, we've had a couple of meetings, 2 or 3 meetings, Teams calls, where literally we had an agenda to run through, which was looking at what the new blood sampling would mean, how that would take place. And I think everyone was getting really excited about it. All the patients were, but the reality is that it needs to go through testing first and validation, I think. So although it may not necessarily benefit my generation, I'm certainly looking to it'll benefit, hopefully, if it gets validated, it'll benefit the future generations and my kids or and everyone else's children who are on the various meetings, feedback meetings. So I mean, really, Emma and her colleagues just run through what may happen and how it may work out and how we've been involved, and really trying to get our feelings and our thoughts about whether we thought it would be a good idea, and certainly anything which gives earlier indication that there may be a problem as a patient was a big tick.
Amazing. And you've mentioned that you've had that help from these kind of patient groups in terms of finding other people that have the same TP53 mutation and finding their kind of support and feeling not isolated anymore. Has there been kind of any additional support that you've found from being involved in this study?
I think that's the main bit, really, but also just to emphasise, there's an open door policy at Manchester.
Yeah.
So after all, it's only a study, so it isn't actually in practice yet. But it was as you said, it was the involvement with other people, and also I think from a personal point of view, it's great to see that we're not standing still, and that science and medicine isn't standing still in this, and that they are looking to whatever they can do to kind of improve early detection, which is, as Emma pointed out earlier, is a critical thing.
Yeah.
You know, if you get a cancer, if it's detected early, you've got a much better chance of fighting it and surviving it. So anything that can get us off that 6 month wait for the radiographer report is important, really.
I can imagine. And Emma, what have been your main learnings from your patients? Because they're obviously this massive cohort that sit in this study and they feed information. What have been your greatest learnings from that?
I would say, firstly, actually, it's really humbling, because the willingness and dedication of patients and families to participate, it's immense, and it is really humbling. So actually, I think it is incumbent upon us as doctors and scientists to make sure that our at-risk patients and families are offered the very best science that the world has to offer. And actually, for rare disease, it is about global cooperation. No single centre can do this by themselves. So having teamed up with our colleagues in Toronto, who are so willing to share their expertise, that means that effectively, you live in Yorkshire, you live in Manchester, you still have the same access to that global leading science. So that's one thing. I did mention it earlier. For me, actually, it was really the feedback from the patient group about, actually, please don't just have a fabulous blood test that can all be done at home, and we don't need to go to the hospital or need to see a doctor, which is, I find that a real learning point, because if you'd asked me cold, I probably would have not come to that conclusion. And for all the population screening programs for sporadic cancers, it's all about bringing early detection out to the community, out to the shopping centre, out to the football stadium. But for individuals who carry these high-risk gene alterations, actually that model of care is not the most appropriate, because actually it's not the one they feel most comfortable with. And that is really, really important for us to know that. And I think it also just collectively highlights that when you're designing research studies, you don't come up with your research study and then go to the patients and go, how about it? You actually carry your patients and families with you.
I think seeing someone in person as well as the blood test is a real, because a blood test can tell you whether you have or haven't.
Yeah.
But actually, you don't know, especially if you have an inquisitive mind, what's the latest in terms of TP53 and the alteration.
Yeah.
Is there any more data on it? Is there anything else we should be watching out for as individuals? You find lots of that out on a face-to-face meeting.
I agree.
Yeah.
And actually, I think it's right that people like me in clinics should be kept on our toes.
Yeah.
Oh, right. Okay.
I might regret saying that, but it's true, actually, and not just yourself, we have other patients and families who are saying, Emma, so what are you doing about this?
Come on, Emma.
Exactly.
Solve it.
So that is why then, for example, when you go to these meetings, you have to reach out to your international colleagues and you have to. I just think it's morally incumbent upon us to offer that very best world-class science to everybody, no matter where they are.
Yeah.
Can I ask a question now, Emma? What are the kind of timescales then? Because it's a number of years, isn't it, before the validation may happen? Sorry, I don't want to jump on Sally.
You're going to get my job, Nick.
But I'm just intrigued to know. So
No, so the truthful answer is I don't know. What would I hope as a realistic aspiration, shall we say? I would hope that in 5 to 7 years' time, we are doing blood tests that then don't replace imaging, but perhaps are more the first step rather than then having the whole body MR. And if that shows an anomaly, to then needing the scan that might look at that particular body part. One challenge with these early detection blood tests that is being worked up but not quite cracked yet is it's one thing getting a signal in the blood of perhaps an underlying cancer, but it's then, so it's got to be specific to the cancer, but then which organ is amiss? And that is actually quite a second challenge.
Lots of challenges. And how frequent would those blood tests be? Would they be kind of one time a year? Like what are you envisaging?
I would envisage, and I use the word envisage, I would have thought probably twice a year.
Okay. And would that be in a routine GP setting, or would that be them visiting the clinic in Manchester?
So touching on what we were chatting about earlier, I think, and again I'll be guided by Nick, that perhaps that's sort of a once-a-year trip to the hospital and then the 6 months in between, perhaps having a blood test that can be done locally and popped in the post.
I think that'd be the perfect combination, actually. Yes, I mean, we talked about quarterly, but that could be something to look for in the future.
Yeah.
Because, of course, 3 months could make a difference after
exactly.
all. But yes, a combination of one local blood test and one face-to-face would be a sort of big improvement, a big step in the right direction, I think.
And I'm going to ask you to speak on behalf of other patients here, the kind of the input that you've had from them. Is that the general consensus that they'd feel more comfortable, obviously keeping that whole body MRI annual scan and then having that kind of spattering of blood tests every 3 or so months?
Yeah, that was definitely the conclusion. I think the interesting thing from the patients was, you think the way I feel personally is that the same as everybody else feels, and we all have the same insecurities about having this genetic alteration.
Yeah.
And the worst part about any test, and this came out, I think, in the feedback sessions, is you have the test and it's the waiting period between having the test and getting the results. So I think one of the really important things with the blood test would be, if it does come into proper practice, is getting a quicker response, or not having to wait 6 months or 3 months even for your blood test results, because it's the waiting time which is the anxious bit. And if you're having your test every 3 months or 6 months, then that's great, so long as you get the feedback and the kind of results from the tests.
Yeah. And as we know, kind of cancers can develop quite significantly sometimes within that 12-month period. So then putting in those intermittent blood tests is quite important for picking up a cancer early. So it's great. It's really promising. Look at you go, Emma. Look at you go. And Nick, again, do you feel more knowledgeable about the TP53 mutation having been involved in this study? I mean, you're saying you've not got that science background, so it can be quite hard to kind of get your head around these words, mutations, genes, like all these kind of buzzwords that are chucked in there.
Certainly, from being on the Teams calls, there was lots of buzzwords used.
Yeah.
And occasionally we had to go and slow people down and say, "Can you just explain what that means, please?" That acronym. But no, I think over the last 2 years, my knowledge of TP53 and LFS, I can even pronounce it now actually, is much better. And I think when you're more informed, you understand what it means more. You feel better about it. You feel it's not a great situation, but you feel better about it, because I think information is really important here. And the more information you have, the better understanding you have, the better you deal with it, really.
Yeah.
So I feel a lot more informed. Hopefully the people in the feedback group, and that feedback group, isn't the whole population. So they are a selection of people who were happy to take part and give their views. Hopefully they'll feel a lot more informed as well.
Great stuff. And Emma, what are your next steps for this research then? So when do you finish?
So we are continuing to get blood samples from both new patients and sequential samples. We have started analysing them locally here in Manchester. And I think a really important aspect of this study is, in terms of the science, it is actually based on data sharing. So with increased computing power, not other than sending samples across the Atlantic to make sure we're both doing the same science, each early detection test is actually, the interpretation of it is only as good as the total number of tests. So there will be a big piece of work which has already been started by our bioinformatics colleagues in terms of data interpretation and data sharing. So that'll be the next thing to come out.
Okay, so we'll stay tuned with you for the next couple of years and see where you're up to.
Indeed.
Incredible. So I guess a final question to both of you would be, what are your hopes for the future? And I guess not just in LFS, but more in terms of hereditary cancers and that, the outlook on that. Nick, I'll come to you first.
Right, yes, because I'm sure Emma's got a much better answer than I have here. I suppose for me, as I just repeat, it's about early detection. I suspect there are lots more hereditary genetic alterations out there that haven't been discovered. So hopefully for other people, they will be continually, the speed of those discoveries will be improved.
Yeah.
But for me personally and my family and for the other TP53 patients, I think we're just wanting early detection. We've got the gene, we were born with the gene. Nothing we can do about that. It is what it is. It's not like you can go back in time and change something. So it's really a case of getting the early detection of any cancers. And also I think understanding what type of cancers you should be looking out for.
Yeah.
And I think it may differ. Again, Emma will mention this, but it may differ between men and women.
Yeah.
What kind of predispositions you may have. But I think all of that information is really important, because it just makes you more aware and keeps you more alert as to those specific areas that you should be looking for. So it's all about early detection. So hopefully that will the research and the validation will happen, and we can get that in the future.
Yeah. And do you hope that your kids, if unfortunately they do have this TP53 mutation, will be in a better standing than, say, you were or your kind of mum and sister were, unfortunately?
Yes, definitely.
Yeah.
I mean, first of all, they'll be aware. And you go through counselling before you actually even get the results. So, you know, because some people may not even want to know they've got the gene. They want to be, happy living obliviously.
Yeah.
And that's fair enough.
Is that an option?
Yeah, I mean, yes, it is. As far as I understand, you can, because some people don't want the stress of knowing they've got a gene which may cause them problems. So you do have to go through a level of counselling before you actually, before you're accepted to take the test and be given the results. So yeah, for me, I wanted to know the results. I'd rather know what I've got rather than kind of living without the knowledge. And certainly all my kids seem to want the same as well. Did I answer the question there?
Can't remember what I asked. I think I asked if you felt like your kids were going to be in a
better situation,
better position. Yeah.
Yes, I think information is improving all the time.
Yeah.
And in the same way that this gene got upgraded from a low risk to a high risk, I'm sure that it may not be information you want to hear, but the more information you get like this, the more the bigger population and the bigger samples you get of the types of cancers and the impacts on men and women differently. That's all good stuff if you've got the gene. So it's all about information and early detection, and that's kind of what I'm really hoping the future will bring, and future science will improve as well.
Yeah, and I guess with these sorts of things, it's when you find out that this is your diagnosis, you might feel out of control. So trying to reclaim some form of control in your life must feel quite empowering, irrespective of if that's, it's still not an ideal situation. Nobody can say that it is. But the fact that you're doing everything within your means and the means of the healthcare system must be quite reassuring, maybe?
Reassuring, and also that it's not a private health thing either. It's open to everybody. So well, I say it's open to everybody. I don't know nationally whether that's the case, but people. I say to people having an MRI scan, my annual scan, and they say, "You lucky thing." I don't have an annual scan, and actually, my first scan, it picked up lumps and bumps, which I didn't know I had, which were taken out and they were fine. So, I feel a little bit fortunate in a way that I'm having the scan. And I'm having it because of the genetic disposition, the genetic alteration.
Incredible. And Emma, coming to you, what's your hopes for the future of LFS and hereditary cancer research?
So I think Nick's actually answered that really quite beautifully.
I've stolen her answer.
You have. But actually, I was at just last week, the LFS patient meeting in London. And they were looking back. So they set up, I'm going to say about 10, 12 years ago. And Nick, as you've illustrated, they were saying, actually, 10 years ago, the decision was, do I have the test or do I not? Now, it's very much around what do we do with this information and how do we use that information for good. So then you think, well, crikey, in 10 years' time from now, the questions that are being asked will be very different. I personally think, looking to the future, my dream and desire would be to have a clinically validated blood-based early detection test of circulating free DNA. I think we really need to sort of crack that basic science of what are those very, very early changes that are occurring in our tissues, and particularly where there's a TP53 gene alteration, because you could argue if that gene alteration is present in every cell of the body, why, whilst the spectrum of cancers might appear wide, is it still sarcomas, childhood adrenal tumours, brain tumours? What is it about those tissues that's particularly vulnerable? And having cracked, if you like, the early detection, it's, I think, the next step that is really going also to come to the fore in the next 10 years is interception. That is kind of the lingo for how do we zap a cancer when it is so very small. And I think a real promising future area is going to be cancer prevention and cancer interception vaccines.
Oh, vaccines. Look at that. It's a nice mic drop there, Emma. So just to kind of summarise, we've covered LFS. So this was it discovered in the 1990s?
So actually, one thing I was actually going to mention, I was sat there listening to Nick thinking, darn, I didn't mention this. So Dr. Li and Dr. Fraumeni.
Yep, Fraumeni, what the syndrome is named
yes,
after.
And there's a Dr. Fred Li. I've met his wife, and Dr. Fraumeni, who's still with us, and I actually met him last year in the States. So they, way back in the 60s and 70s, described these families with this really marked cancer predisposition. The TP53 gene was identified as being causative back in the early 1990s. Yeah. And the chap who did that was David Malkin in Toronto. And David Malkin has reached out to me, and I mean, he emails me probably once every couple of weeks. And again, and I should have said, he is integral to this research. And we have lots of other joint projects going on for our Li Fraumeni families.
Amazing. So yeah, we've got that. We've discussed Li Fraumeni, we've discussed the cancer predisposition, and then obviously, Nick, your diagnosis and what that means for you and your family, and then the Atlas study and the hopes for the future. So I really hope you guys have enjoyed that wee little tour of Li Fraumeni syndrome and hereditary cancers. And I just want to say a massive thank you to both of you, and especially Nick, because you being type A patient or pre-Viva, whatever you want to call it, are integral to this research and integral to those kind of progressions in terms of this research. So, you know, learning that you've got this sort of thing is not easy, but then also using it to empower yourself and other people is, you know, it's really humbling. I know we've used that word a lot, but I think that's the word of the podcast, really, humbling. So thank you so much for sharing your story and being so open and honest about it. I know it's not easy to have these open discussions, but I hope that this can help other people and other patients. And it shines a light on the work that Emma's doing and the amazing progress that's being made. So yeah, thank you guys.
No problem at all. It's been nice to be with you.
It's been a pleasure. Thank you.
Oh, fabulous. Well, thank you for listening, everybody. Tune in next time, but I hope you enjoyed that episode as well. I'll put all the links in the show notes so that you can have a bit of a read around Emma's research and the study. And yeah, that's all for now. Bye.
Bye.
If you have been affected by anything you've heard in this episode, please see the show notes for a list of charities and organisations that can help.
1 in 2 was brought to you by the University of Manchester and the Manchester Cancer Research Centre. Listen to our next episode to hear from more of our researchers as they share the innovations, discoveries and projects that are changing the landscape of cancer prevention, early detection and treatment. To find out more about what you've heard today, please see the show notes for this episode, where you'll find a transcript and links to further information and research. Cancer is one of the university's 5 research beacons, showcasing the interdisciplinary collaborations and cross-sector partnerships that are tackling some of the biggest questions facing the planet. To hear more about Manchester's research in advanced materials, biotechnology, cancer, energy and global inequalities, go to manchester.ac.uk/beacons.